Thanks very much, Dr. Goldenberg. Good morning, everybody. So, as advertised, I'm going to talk this morning about quality of life after the treatment of localised prostate cancer. So when I tried to, when I was thinking about an image for quality of life, I came up with this. Now, I don't have prostate cancer, but I was attending a prostate cancer conference at the time in Cancun, Mexico this year, so a little tenuous perhaps. So why am I talking about quality of life today? Well, there are several reasons. First of all, this is really an important issue and probably doesn't get enough airtime, or at least the airtime that it deserves. I think a lot of people might view this as a bit of a soft science because you don't have the hard endpoints of overall survival or disease-specific survival. But I think that until we know which treatment is best for localised prostate cancer, which might never happen, it's arguably the most important issue in this area. And I don't think that's lost on this department. And as you probably know, Dr. Joyce Davison, who's here today, has published on this. It happens to be the 10th anniversary this year of the first validated prostate cancer-specific quality of life instrument. I'll tell you exactly what that means in a moment, so that's cause for some celebration, I guess. But finally, there was a recent and I think very important study in the New England Journal of Medicine which came out just in March, and I'm going to go over that in some detail later on. So this is an outline of the talk this morning. I'm going to give you a definition of quality of life, talk about why it's important, also mention ways in which we can measure quality of life, and then, as I mentioned, just go through some of what I think is probably the most important literature. In terms of the definition, what is health-related quality of life? And you'll see this acronym in the literature. It's based on the World Health Organization definition, which was put out back in 1948 of health, whereby health is not merely the absence of disease, but it's a state of complete physical, emotional and social well-being. So health-related quality of life, being based on that, is therefore the physical, psychological and social domains of health. And as you'd expect, it's influenced by a person's experiences, beliefs, expectations and perceptions. In the realm of disease and treatment, what that means is that we're talking about their symptoms, the degree to which these symptoms bother them and the impact they have on their functional status. An important point about quality of life is it's got to be the patient's perspective, not the doctor's. It's pretty clear now that we tend, as physicians, to overestimate our patients' quality of life. So why is this so important in the realm of localised prostate cancer? In most cancers, when they're diagnosed at a curable stage, survival, or the duration or quantity of life, is of prime importance. Quality of life is still important, but it's very much secondary. And I'd like to take you through a very simple example to illustrate this. Let's take a 55-year-old man. He's got early stage colon cancer in the ascending colon. He has a right hemicolectomy. He's cured. Quality of life's unchanged post-operatively, and then he dies of an unrelated cause 25 years down the track. Let's say this exact same man, for whatever reason, refuses treatment. His cancer goes on to metastasise and kills him in 5 years. It's pretty obvious that he needs treatment because he's got a survival benefit of 20 years. Quality of life, on the other hand, in this scenario is very much secondary and quite unimportant, and that's because it really doesn't factor in. In treatment, perhaps the only quality of life issue that might arise is a very small risk of perhaps a temporary stoma if the surgery doesn't go quite as planned. When diagnosed at a curable stage, so in localised prostate cancer, the situation can be totally different, especially when we're dealing with low risk, which we see all the time now. Quality of life might assume equal or possibly even greater importance than survival in these patients, and I think there are four main reasons why this is the case. First of all, being a slow-growing tumour, active treatment, as we now know, may not confer necessarily a survival advantage. Let's take another pretty simple example. You've got a 70-year-old man with a PSA of 6.5. He gets a biopsy which comes back as Gleason 3 plus 3 equals 6. He elects to have treatment. Let's say he has a radical prostatectomy. Unfortunately, he develops erectile dysfunction post-operatively, but then he dies of an unrelated cause because he's cured, say 15 years down the track, of heart failure. Again, take the same man. Instead of choosing treatment, he goes on watchful waiting, in which case he has an active sex life for another 5 years before he loses interest, and then he dies at 85 of an unrelated cause. And at the time he has asymptomatic non-metastatic prostate cancer. So in other words, prostate cancer hasn't progressed. Survival is not affected by treatment in this situation, but quality of life certainly is. And this gets back to the old adage, primum non nocere, which, as you all know, is Latin for first do no harm. I actually looked this up because I always assumed this came out of the Hippocratic Oath, but it's actually totally unrelated. Well, it's not totally, but it is. It's not from the Hippocratic Oath. It's actually first arose from a medical text in the 18th century. A little bit of trivia there for you. Point number 2 is that patients typically live for well over a decade post-treatment, and this is regardless of whether the cancer is cured or not. This is further accentuated by our earlier detection due to PSA screening, which might even add another 7 or 8 years to this. So patients have to live a long time with the effects of treatment. Number 3, the standard treatment modalities that we have similar survival rates, but very different side effect profiles, and we'll see that later on. And finally, all the treatment modalities that we have available may cause varying degrees of impairment to bodily functions, not just any bodily functions, but really intimate bodily functions. And this is because of the delicate or perhaps unfortunate anatomical location of the prostate, such that local treatments can cause dysfunction in the sexual, urinary, rectal or bowel domains of quality of life and have a really major impact. So before I go on, there's just a couple of points, general points I'd like to make on quality of life. And these really come from reviews that have been done on the subject. The first one is that the severity of a symptom does not necessarily correlate with the degree of bother. An example of that, which we see all the time in clinic, is a patient who presents not with cancer but comes in with lower urinary tract symptoms, and they've done their International Prostate Symptom Score, and they have, say, a low score of 10 out of 35, but then on their bother score, it's 4 or 5 out of 6. Doesn't necessarily correlate. Or conversely, let's say you've got an 82-year-old man with complete erectile dysfunction, no erections at all, but he's not bothered at all either. So specific symptom deterioration post-treatment can even be associated with general improvement in quality of life. So that's an interesting phenomenon, and it's presumably due to a mental shift whereby the consequences of treatment are accepted and adapted to as long as cancer cure is at least attempted and hopefully succeeds. Okay, this is just a symbol of quality of life, at least for me. This is my daughter Harriet, who's turning 7 in August. Just thought I'd use that as an excuse to get in some family snaps here. Okay, moving... Yeah. Oh, okay. Can you turn the microphone off at the remote site there, please? Thanks. So measuring quality of life. We have various instruments which are questionnaires available, and these have become available in recent years. They can be categorised into generic, cancer-specific, and in our case, prostate cancer-specific. So an example of a generic instrument is the SF36, and this is considered the gold standard for a general quality of life. There are 8 domains within... Yeah? Yeah.
Getting back to the last slide.
Yeah.
What percentage of patients, what percentage of patients do you think, what percentage of patients have psychological or self-improvement quality of life because they feel they're cured of cancer as opposed to accept side effects?
Yeah.
As opposed to people who are cured of cancer but can't accept the side effects. And because it really is an individual thing.
Sure.
So quantitative analysis will vary each person with each data that you're talking about.
Yep. And I think that's a limitation of the studies we do, and it's an unanswerable question because it is so individualised. That's right. Yep. In terms of generic instruments, there's the SF36, which is the gold standard. There are 8 domains within this instrument, including such things as the patient's social function or questions on social function, emotional well-being, and limitation of their role in society. In distinction to general quality of life, there are cancer-specific quality of life instruments, such as the QLQC30 and the FACT-G. And the domains in these questionnaires are really significant for the spread of different types of cancer patients, so they include things like nausea, fatigue and pain. And then in our neck of the woods, we've got the prostate cancer-specific questionnaires. I'll just talk about a couple today, which I think are probably the best and are certainly the most relevant with regard to the literature that I'm going to be talking about. So the first one to come out that was validated was out of UCLA, the Prostate Cancer Index, and that was 10 years ago, as I mentioned before. It comprises 20 questions, and there are 6 domains within this questionnaire which assess the 3 particular domains that I've already talked about: urinary, sexual and bowel or rectal function, but not in function, but importantly bother as well. This PCI was then altered to create the EPIC, which is the Expanded Prostate Cancer Index Composite, published in 2000. So it's a modification of the original, but still assessing both function and bother in all those domains. It was stretched right out to 50 questions from 20, so a lot of questions added, including the addition of questions on irritative symptoms, which were not included in the original PCI. And therefore, this is much more sensitive for picking up the impact of the radiation modalities for treatment of localised prostate cancer. In addition to that, a whole extra domain was added, and that was that assessing the effects of hormone therapy, which is also appropriate given that hormone therapy is commonly used as an adjunct to radiation therapies. The EPIC was then further altered. This time it was reduced from 50 questions down to 26, whereby the overlapping items were excluded. And I guess this makes a lot of sense given that 50 questions is probably pretty burdensome for patients to take on, and 26 is going to be much more feasible for them to complete. It has been shown that there is a very high correlation with the EPIC 26 to the 50 questionnaire. In terms of how these questionnaires are scored, with the EPIC 26, and indeed the same for the original EPIC, there is a Likert scale of responses, and I'll show you this in just a moment, these are converted to a scale of 0 to 100, and what's important to remember is that the higher the score, the better the quality of life. If you want any more information about these EPIC questionnaires, you can go to that website, or you can just Google EPIC 26 and you'll find it all freely available. It's out of the University of Michigan. So this is a very busy slide. I don't expect you to be able to read it. I'm going to just highlight some various aspects of it. You can see here, this is the EPIC with the 50 questions, and you can see the 4 separate domains there: urinary, bowel, sexual and hormonal. Within urinary, there are both questions on incontinence and also lower urinary tract symptoms, and there are questions on function and bother within each domain. So in terms of the EPIC 26, they really picked the eyes out of this to get rid of the overlapping items, ensuring high correlation, and the questions that I've put the red boxes around remain in the EPIC 26. In terms of scoring, this slide is simply to show you how the initial response to a question is converted into a standardised value out of between 0 and 100. So if you look at the middle column there, the questions either have anywhere between 3 and 5 potential answers, which are then converted to a standardised value. So in working out the sums of these, it's a little bit labour intensive, and I think that's perhaps a little disadvantage of this particular scoring system. To work out the summary for a particular domain, however, that's fairly straightforward. You just take all the standardised values that you've collected within that domain and take the average. Okay, moving on to the types of studies looking at quality of life. They're really broken down into the 2, cross-sectional and longitudinal. With Within the cross-sectional study types, these are really a snapshot in time of post-treatment quality of life. They're easier to conduct than the longitudinal studies for that reason, and therefore they're more prevalent in the literature, but they have the obvious limitations, therefore, of not being able to assess what happens over time, and in addition, you're unable to control for baseline or pre-treatment differences in patient characteristics. The longitudinal, on the other hand, or conversely, the advantages over cross-sectional are the same as the disadvantages of cross-sectional, so they do assess quality of life over time, and I think in the realm of prostate cancer, this is especially important when we're dealing with such a long period, and we do know that changes occur over time. And in addition, there is the potential to account for baseline. I'm just going to briefly summarise some results of cross-sectional studies and then go on to the main two longitudinal studies. This comes from a review by Dr. Penson published in 2003. What has been found across the board is that the general quality of life is really unchanged by treatment of localised prostate cancer, but in contrast, the prostate cancer-specific quality of life, the domains of which I've just shown you on that questionnaire, treatment in that area, treatment does appear to have a profound effect on sexual, urinary and rectal function. As you'd expect, incontinence generally is worse with radical prostatectomy, but rectal problems are worse with radiation modalities. Having said that, despite age-matched controls, we can't conclude definitively that these results are true treatment effects because being in cross-sectional studies, as I just mentioned, we don't have a baseline. So that's why we need longitudinal studies. And I'm really going to spend some time talking about what I think are probably the two most important ones in the literature, and particularly the most recent one. This is Olive, who is 5, and she's this is another symbol of quality of life. Here she is exploring the streets of Vancouver, collecting magnolia petals. Okay, so moving now on to the current data, and this was published just 2 months ago by Sander and multiple colleagues, various institutions, so it's a multi-institutional study, so it's got that advantage, it's prospective, and I think what's really important, one of the really important factors about this is that it's assessing modalities of treatment which are currently used. Okay, so it's not something from 10 plus years ago where our treatments were vastly different. So, for example, with radical prostatectomy, patients within that cohort have had either open or pure lap or robotic prostatectomies. Nerve sparing was also stratified for, which we'll see. And in terms of external beam radiotherapy, it's looking at patients who have had 3D conformal therapy and also intensity modulated. Within the radiation modalities, also the adjunctive or adjuvant hormone therapy was stratified for as well, which is important. It's a longitudinal study, as I mentioned, so there are assessments at baseline, but also at 2, 6, 12 and 24 months, so it's out to 2 years, with enrolments between 2003 to 6. More than 1,200 patients were included in this study, and importantly, more than half of them, their partners were also included. So that's another important thing to remember about quality of life in this situation, is that when you're treating localised prostate cancer, you're not just affecting the quality of life of your patient, but also their partner. Parameters assessed were changes in quality of life, which we'll go into some detail in just a moment, but also the associated distress in their partner, and finally satisfaction with treatment outcome. So they used the EPIC 26, which is why I've been focusing on that earlier this morning, and they also used a questionnaire to measure outcome satisfaction called the Service Satisfaction Scale for Cancer Care. In terms of follow-up, less than 10% did not complete follow-up. This table shows you that at 6 months, the 6 months was rather the minimum follow-up of patients, and then still two-thirds of the original cohort had follow-up to 2 years, but as I say, about 10% of them did not complete the questionnaire. So looking at at numbers by treatment modality, you can see of the 1,200 patients, about half of them had surgery. The other half were fairly evenly broken down into external beam and brachytherapy. Looking at the radical prostatectomy cohort on the left-hand side, you can see that the vast majority had nerve sparing. Only a small fraction had non-nerve sparing. One of the limitations, however, of this study is that nerve sparing was not broken down further into unilateral and bilateral nerve sparing, which of course can make a potential difference in sexual quality of life post-op. In the radiation group, 2/3 of patients had external beam alone, with 1/3 having adjuvant hormone therapy, and in the brachy group, the vast majority had brachytherapy alone, with a small percentage having mixed treatment. Now, the final group there is a bit of a mixed bag because it's brachytherapy plus hormone therapy or external beam or both. So let's look at the results now, and these have really been represented in two very different formats, so I'll just go through one at a time, and starting off with the sexual domain. And focusing really on the left-hand side, just looking at the prostatectomy results here. This is over the 2-year period. And this is the mean quality of life score on this questionnaire. So starting out pretty high. With radical prostatectomy, you can see that there's a very sharp drop and then a gentle rise until plateau at about 2 years. Not sure if you can, I think you can see the asterisks there. You can make them out. They indicate not only a statistically significant but also clinically significant difference from baseline, and that's been previously determined as being greater than half a standard deviation from the baseline. As you can see, there are two different curves there for post-radical prostatectomy, and nerve sparing certainly led to a better sexual quality of life. I think the explanation of the difference between the nadir here and the end recovery is most likely going to be the neuropraxia. And certainly plenty of work has been done on this in the past, but it needs further work because it's really a disadvantage of the surgical approach in that the early post-treatment quality of life, as you can see, is really quite significantly affected. And interestingly, just in this month's BJU, there was a good article coming out of James Easton's group at Memorial Sloan Kettering, looking at their results with a completely traction-free dissection of the prostate, which showed an absolute increase at 6 months of continence of 20%. Still looking at the sexual domain, so this is still the same graphs, I've just moved on to the next slide. Looking at radiotherapy, you can see that the curves are quite different in the middle there, whether hormone therapy is given or not. What's really interesting, though, is that 94% of patients had less than 1 year of hormone therapy, and yet the change in quality of life is quite apparent right out to 2 years, so well after cessation of the hormone therapy. And you can't really discern the effect of hormone therapy on brachy because, as I mentioned, it's a mixed group. But that really, I think, dampens one's enthusiasm for giving hormone therapy adjuvantly in patients other than high risk. Looking now within the urinary domain, and specifically the incontinence side of things, again you can see a sharp drop-off with surgery and then a recovery, most of which has occurred by about the 6-month period. And again, I think this again represents another disadvantage of radical prostatectomy, which really needs to be further improved. Funnily enough, there was also an article on this in this month's BJU, and PRDMP stands for posterior reconstruction of Denonvillier's musculofascial plate. A fair bit of work has been done on this in the past, but it's really been popularised, I think, by publications by Rocco, who appears to have excellent early continence results, and I think that's something we need to be pursuing. Interestingly, also, with regard to this domain in brachytherapy over on the right-hand side, is that there is significant reduction in quality of life in incontinence out at 2 years with brachytherapy. So that's, at least to me, somewhat surprising. Within the urinary domain, looking specifically now at lower urinary tract symptoms, non-incontinence, we find that LUTS are actually improved after radical prostatectomy, and this is not new, and really corroborates work done by Scardino's group out of MSK, who have shown improvement in lower urinary tract symptoms after radical prostatectomy. But interestingly, and again somewhat surprisingly, I think that the quality of life at 2 years for external beam radiotherapy is also above baseline, and which is interesting. Looking over now at the brachytherapy graph, although there is improvement after the initial nadir, again, out to 2 years, the quality of life remains below baseline for lower urinary tract symptoms. In the rectal domain, as you'd expect, no change for the surgical patients, but with the radiation modalities, both of them have significantly reduced quality of life out to 2 years. And finally, in the hormonal domain, looking at radiation and external beam and brachy, again, hormone therapy reduced quality of life in these patients, or certainly in external beam patients, significantly, and again out to 2 years with external beam. And this again is in line with what we saw in the sexual domain, where even though hormone therapy is completed much earlier, there are ongoing effects in terms of quality of life. And this is the second way in which this data or the results were presented, which is really completely different. This is not, these numbers that you're seeing here are not the actual quality of life scores, as I've just shown you previously. Instead, these numbers are percentages of patients reporting specific levels of distress or dysfunction for each of the quality of life domains, and they're mean. They're not mean, they're percentages. So I'm just going to highlight some of the more important ones. You can see here that within the prostatectomy cohort, and this is, I'm just going to look at the summary of domains here. So overall urinary problem. So this actually includes lower urinary tract symptoms and urinary incontinence. And at 1 and 2 years, 7% of patients complained of a reduction in quality of life. Now, how did they measure that? Well, these results were dichotomised such that if a patient said that there was moderate or greater problem in that domain, then that was included. That was a yes. If it was less than that, that was a no. So that's how they have arrived at these percentages. So 7% at 2 years. However, at 1 and 2 years, you're looking at 11% for external beam radiotherapy. So this is for an overall urinary problem. And for brachytherapy, you're looking at 18% at 1 year and 16% at 2 years for an overall urinary problem. So what this implies, perhaps, is that maybe the lower urinary tract symptoms actually carry more weight than the incontinence in terms of quality of life reduction. Looking now at overall bowel or rectal problem, as you'd expect, only 1% at 2 years with surgery, but around 10% at 1 and 2 years for both brachytherapy and external beam radiation. And then finally looking at the overall sexual quality of life, much higher percentages involved, as you'd expect, with 43% at 2 years for surgery, 37% at 2 years with external beam, and 30% with brachytherapy. With regard to the other outcomes, so for each domain, it was found that changes in quality of life were significantly distressful for the partner. In terms of outcome satisfaction, this was measured at 1 year, and for the patient, the outcome satisfaction was significantly associated with changes in sexual, hormonal and the LUTS domains. And for the partner, as you might expect, outcome satisfaction was significantly associated with changes in the patient's sexual quality of life domain. So to summarise this paper, I think what we see here is evidence supporting what we see in the clinic, but there's also a few surprises. In particular, there are significant incontinence problems at 2 years for brachytherapy. There are ongoing lower urinary tract symptoms and rectal problems for brachytherapy out to 2 years. There are ongoing hormonal problems after cessation of hormonal therapy. And there's also a suggestion that lower urinary tract symptoms reduce quality of life more than urinary incontinence. And in fact, I noticed that this was corroborated in an abstract presented at the AUA in Orlando just gone. From our point of view, I think there's a lot of room for improvement in the short-term period post-radical prostatectomy, and I think this is going to come from avoiding traction on the neurovascular bundle and techniques to stabilise the urethral sphincter. Study's got limitations. It's not randomised. What I didn't mention at the beginning is that there was a statistically significant difference between the treatment groups across all pre-operative or pre-treatment characteristics. The only one that wasn't significantly different was body mass index. So selection bias may have influenced the outcomes. And as a result of this, although it's very tempting, we really shouldn't be using these numbers to compare between modalities because it's not randomised. We're looking at different populations of patients. But we can use them to at least guide patients as to their post-treatment expectations within a modality. As I mentioned, nerve-sparing radical prostatectomy wasn't stratified further into unilateral and bilateral nerve sparing, so that confuses the issue a little there. And there was no watchful waiting or active surveillance arm, which may have been helpful given that that is certainly a valid management option of localised prostate cancer. And really 2 years is actually quite a short follow-up in this setting. So the next study that I'm going to talk about has a much longer follow-up. This is the second last family SNP. This is Audrey, who's 3, expressing her opinion of my talk. Okay, looking at long-term data. This was reported in the Journal of Clinical Urology back in 2005. And what this was a new assessment of a cohort that was previously studied as a cross-sectional study. So there are no pre-treatment or baseline values in this study, which is a limitation. So the comparison in this particular publication was between the first post-treatment and the second post-treatment, which was about 4 years later on. Patients had received either radical prostatectomy, 3D conformal radiation or brachytherapy, and they were also compared to a control group. There were over 1,000 patients in the initial analysis, and the median post-treatment assessment time was about 2.5 years. And that's for the first analysis, not the second. Selection was based on consecutive patients who had had radical prostatectomy, external beam or brachy at a single institution from 1995 to 99. Given it was those years, it's not mentioned in the paper, but presumably the radical prostatectomies were almost all open. The control group was formed by taking age-matched local volunteers with no history of prostate cancer. So for the current or for the second study, the second analysis, there were just under 1,000 eligible men, and most of those had had surgery, 147 external beam, 84 brachytherapy, and there are 112 patients in the control group, or people in the control group. 709 of those consented, representing a response rate of about 73%, and that percentage was similar within each treatment group. So the median post-treatment time of the second analysis was over 6 years. So the difference between the two is nearly 4 years. And the range of the second analysis was between 4 and 8 years. Now there were significant differences between the treatment groups. In the external beam radiation group, they were significantly older than other treatment groups, which is often the case, usually the case. Their median age was 76 versus a median age of 67 to 70 for the others. Interestingly, 2/3 of the brachytherapy patients also received hormone therapy, which was quite a different proportion from the other two treatment arms, which were 1/3 each, and 1/3 of patients having additional hormone therapy for radical prostatectomy I thought was a little unusual. Quality of life instruments used were the short form 12, so that was for looking at general quality of life, and again they used the EPIC 26. In terms of results of general quality of life, what they found was that they were similar, not only between treatment groups and controls, but also between the first and second analysis. So what we can see here with regard to long-term data is that treatment does not seem to interfere with general quality of life up to 8 years after treatment. But let's now have a look at prostate cancer-specific quality of life scores. So this is getting back to a score out of 100 where higher is better quality of life, and using the EPIC 26 domain. So I'll take you through this table. First of all, you can see in the control column there quite high values as you'd expect for urinary and rectal quality of life, but as you'd also expect, a much lower figure of 63 in the sexual quality of life domain. This is in the ageing male population. If you look then at the radical prostatectomy column, what you can see are two asterisks there, which represent a statistically significant difference from the control group. So, in other words, urinary incontinence was statistically significantly worse in quality of life post radical prostatectomy, and these are at 6 years post treatment, and also in the sexual domain much lower with a mean score of 39. With external beam, you can see that the significantly lower quality of life domains were rectal and sexual, but for brachytherapy, all domains, and urinary, as you can see, has been split into both LUTS and incontinence. All domains showed a significantly reduced quality of life with a mean of about 6 years post-treatment. But what happened? So what actually was the difference, though, between the first analysis and the second analysis? So let's have a look at that. In the control group, there was a significant drop in the sexual quality of life between 2 and 6 years, rather. In the external beam, there was a significant drop in incontinence. So right out to 6 years, incontinence after external beam is still showing a deterioration in quality of life. Similarly, for the sexual domain, there is an ongoing deterioration out to 6 years for external beam. And for brachytherapy, also, incontinence continues to deteriorate. But for brachytherapy, there was also an improvement. So there was an initial drop in lower urinary tract symptoms for brachy, which then started to improve, or we've seen an initial drop from the previous study, but from the 2 to 6 period you can see that there's improvement, and similarly there's further improvement in the rectal domain. But I think what's really important about this table is that there are no yellow arrows in the radical prostatectomy column. In other words, once you've hit 2 years after radical prostatectomy, your quality of life in these domains does not change. So this long-term data also has limitations. There's no baseline, as I mentioned. So the controls that we used were the surrogate. It's therefore subject to selection bias. So again, although it's very tempting, we really shouldn't be comparing across treatment modalities. It's also potentially subject to non-response bias. So for example, if the majority of the non-responders were older or had poorer quality of life, this may favour, for example, the radical prostatectomy group outcomes. It's a single institution, so it might not be applicable across the community setting. It wasn't stratified for adjuvant hormone therapy, and a clinically significant change was not defined in contrast to the more recent study. So to summarise, for radical prostatectomy patients, quality of life stabilises within the first 2 years. But for radiation patients, and for both modalities, quality of life continues to evolve long-term in different ways for different domains. So in conclusion, quality of life is crucial in patients with localised prostate cancer. This is because treatment may not lead to longer survival. Patients are likely to live a long time after diagnosis, regardless of cure or not. Different treatments that we have available have comparable efficacy but different side effect profiles, as we've just seen. And the treatments do interfere with intimate bodily functions. We've seen that instruments are available to measure quality of life, and they can be used for research, but they can also be used in the clinic, in particular perhaps to determine baseline and hopefully help optimise the patient's choice of appropriate treatment. So finally, I think patients should be informed of the latest and best quality of life data, as long as it's based on current treatment methods, because I think this is likely to guide the individual patient to the most appropriate treatment form for him. And as always, as urologic surgeons, we can do better. So for the future, I think, at least for us, surgical techniques to minimise the reduction, particularly in the short-term post-treatment quality of life, really needs to be addressed and further tested across multiple institutions. And the outcomes of these studies need to be measured using validated quality of life instruments. Finally, These are the women in my life, and as you can see,